Welcome everyone to yet another interesting session of IDEC, and I'm sure you have been enjoying the wonderful presentations from best of the speakers from across the globe. So, a great pleasure to welcome Dr. Ira Goldberg, and to moderate his session, I have with me Dr. Rajiv Koval, who is a very eminent diabetologist from the city of Mumbai in India. And I'm sure you are going to enjoy this session also. Dr. Goldberg is Chief of Division of Endocrinology, Diabetes and Metabolism at Langone School of Medicine at University of New York, and he is going to enlighten us on managing lipids in patients with diabetes. Over to you, Dr. Goldberg, for the next session.
Okay, thank you. Let me try to set this up right. Let's see, share screen. Are we on?
Yes, we are on. We can't see your PowerPoint right now. You have to put on your PowerPoint.
Screen button on the top?
Yes. Yeah, your slide is there. Yes, you can start.
Okay, you can see it?
Yes, we can see.
Okay, so it's nice to be with you this evening. Actually, I walked in the snow yesterday here in New York. I'm going to tell you about lipid disorders in patients with diabetes, and it's my first time doing it in cyberspace. So this is what I always tell endocrinologists. Lipids is endocrinology. I know it's the evening. Hopefully you had some coffee. Stay awake. So I have a couple of conflicts that you should know about. Like many people, I do consulting for a number of companies. I also receive some money for laboratory studies. So these are the objectives of the next 20 minutes or so. I'm going to tell you when to use newer lipid cholesterol lowering drugs. What do we have in addition to statins, and when do you need to use them? I'm going to tell you a little bit about the use of triglyceride lowering therapies, when to use them in acute situations and chronic. So here's a typical patient. Probably maybe you and I see this patient every week. So a 60-year-old man, 3 years post myocardial infarction. He has some hypertension. He's overweight, BMI 33. His diabetes is pretty well controlled. Hopefully, since he has a history of a myocardial infarction, he's on a GLP-1 drug, as you heard about yesterday from Silvio Isnucci. But he has a lipid disorder. He starts off with a cholesterol of 270, an LDL of 185, elevated triglyceride to 250, and an HDL of 35. So what he has is traditional diabetic dyslipidemia, at least to some degree. What we see in patients with diabetes is elevated triglyceride or VLDL, classically low HDL, and small dense LDL. And this is diabetic dyslipidemia in patients with type 2 diabetes. This man also has elevated LDL, and that's not totally typical. People with diabetes and without diabetes, if they're age matched, actually have the same levels of LDL. So this is a question. This is a guy with diabetes and increased vascular disease. And so why does it happen? So is it advanced glycation products? Is it general inflammation? Is it reactive oxygen? Is it his dyslipidemia? Is it his hypertension? So I can give 4 or 5 reasons, and if I'm in a good mood, I could come up with probably 5 more. The real reason is I don't really know, and nobody else really does. But hyperlipidemia clearly is one of the major reasons. So this is a study that is an old study from more than 20 years ago, but I think illustrates this point. So this is a comparison study of the mortality of patients with diabetes who are followed in Joslin Clinic, the Harvard Medical School Diabetes Center, right? And patients who are followed at University of Tokyo. Many people think that that is the Harvard of Japan. If you look at it over the course of 25 years, the patients in Japan had 1/4 to 1/3 fewer, lower mortality than the patients in Boston seen at Joslin Clinic. So what does this mean? So it means perhaps if you have diabetes, you're better off going to see a doctor at the Harvard of Japan rather than the Harvard of the US. Another possibility, probably the most likely, is when this study was done, the average cholesterol in Japan was about 130, and the average cholesterol in the US, 210. So lowering cholesterol makes a huge difference in the outcome of patients with diabetes. Okay, so what do we do with this patient? We put him on a statin, and he's put on a high dose of rosuvastatin. He gets the kind of response you might expect to get from that drug, about a 60% reduction in his LDL cholesterol. His LDL goes from 185 to about 85, and that's what you might expect. His triglycerides might go down a little bit, but often they stay pretty much the same. And his diabetes and HDL also about the same. So is this good enough? It is not. So what we've learned over the last decade or so is if you look at coronary arteries, high cholesterol causes disease. But if you drop the cholesterol dramatically, which we can do now, the vascular disease will go away. Atherosclerosis is a two-way street. In fact, if you drop LDL cholesterol to below 70, 2/3 of patients will undergo regression. Their blood vessel will scar and it will start to open up. So who doesn't get regression? That might be the right question to ask. The answer actually is people with diabetes. And you see it in human studies and you see it in animal studies. But how much cholesterol reduction is enough to cause regression? 2/3 get reduction at 70 or below. This is a study that was done using a PCSK9 inhibitor. So using this drug, we can drop cholesterol levels to levels we have never seen before. LDLs of 50, 40, 20. Almost all of us now see patients who have LDLs that read out as 0. This study looked to see how much a blood vessel would open up as you reduce cholesterol. And even though, the inflection point is below 100, probably about 80, the lower you go, the more the blood vessel opens up. So maybe with cardiovascular disease, LDL can never be too low. And that's the way we think of these patients. So here's some guidelines. So this set of American guidelines in 2018 said, if you have evident cardiac disease or you're at very high risk, even at a high dose of statin, you should put another medicine on these patients. The first one probably is ezetimibe, and that'll drop LDL cholesterol about 15%. But if they're still increased, meaning if their LDL is above 70, you should consider using something stronger, like a PCSK9 inhibitor. What do these new drugs do? So these are monoclonal antibodies. They drop LDL by 60% approximately, and they do that on top of statin medications. This is an illustration of that. So this person on a statin, or this study, looked at people on statin with LDL cholesterols about 120, and they dropped more than in half using the monoclonal antibody. So how does this antibody work? So the PCSK9 here are the little figures in brown. Normally what they do is they bind to the LDL receptor, and when that receptor is internalized, it usually is recycled to the cell surface. But PCSK9 causes the receptor to be degraded. So the net effect is the loss of LDL receptors. By putting a monoclonal antibody against the PCSK9, you prevent it from binding to the LDL receptor, you prevent LDL receptor degradation, LDL receptors go up, and circulating LDL cholesterol goes down. So this is what we use now. These injections occur once every 2 weeks. There's a form where you could do it once a month, and they're extremely effective, but relatively expensive therapy. But this is not likely to be what we will be doing in probably 2 years, or I suspect for sure in 5 years. So this is a different approach to reducing PCSK9. It's a medication called inclisiran. So what is inclisiran? So this is a silencing RNA with a linker on it. It's been described in 2 New England Journal papers that have come out within the last year. An injection of this goes to the liver, where it's targeted by the linker. And since it's a silencing RNA, it associates with the RNA for PCSK9 and causes its degradation. In a big clinical study, not a big clinical study, a rather small clinical study actually, subjects were given this, an initial injection, a second one 3 months later, and then a third one 6 months later, and LDL cholesterol was reduced 50% for 540 days. This is going to be our future. Our patients are going to get an injection once every 6 months, and it's going to lower their LDL tremendously. So stay tuned. So another new drug came on the market. So this drug was approved by the American FDA about 6 weeks ago. So that was just before the COVID epidemic. So it was bad timing for this company. So this molecule, bempedoic acid, binds to an enzyme called ATP citrate lyase. So what this enzyme does is it frees an acetyl-CoA from citrate within the Krebs cycle. And the acetyl-CoA normally is a precursor to cholesterol biosynthesis. So like HMG-CoA reductases, this blocks a pathway of cholesterol biosynthesis. The response to that in the liver is to upregulate LDL receptors, and that leads to a decrease in LDL in the bloodstream. One of the hopes of this particular therapy is that the bempedoic acid is actually a precursor drug, and it requires an intracellular enzymatic action to activate it. That action actually occurs in the liver, but does not occur in muscle. So it's hopeful that the side effects of statin myopathy or statin myalgia will not occur with this particular therapy. But we don't really have those studies yet. Well, how effective is this? So it's not a blockbuster like PCSK9, but it's a good addition. So this is about the efficacy of the drug. So by itself, it will lower LDL cholesterol about 18% mostly on top of statins. However, if you make a combination pill, which is bempedoic acid plus ezetimibe, you can get a 36% reduction or 35% reduction. And so at that level, it's a real therapy. So is there something else we should do for this patient? Type 2 diabetes, cardiovascular disease, some hypertriglyceridemia. And it's clear we have another therapy. So a little more than a year ago, this blockbuster study came out called Reduce It. So there had been a series of studies using omega-3 fatty acids in patients or in subjects who had cardiovascular disease. Some of those were done in people with hypertriglyceridemia. Some of them, and I don't know why, were also done in people without hypertriglyceridemia. And those studies had all failed. This study used a different form of omega-3 fatty acid, isopentyl ether fatty acid, or EPA. The usual omega-3 is a mixture of EPA and DHA, and this was sort of a congener of the EPA. The patients were given a full dose of it, 4 grams. There were 8,000 of them, and they were chosen to be people with diabetes. The study was done in patients on top of statin. They had an LDL cholesterol of 75. They were also initially chosen to have triglyceride levels over 150, although some of them had triglycerides as low as 135 because of the variability of the measurement. But the average patient, the average subject, had a triglyceride of 216. The therapy reduced triglyceride about 18%, and it decreased MACE, cardiac events, by 23%. So this was astounding, and this was a major effect. So why did this work? Why did this work when the other fish oil studies or omega-3 studies did not work? So this is the possibility. They chose subjects who were at higher risk, many of whom already had cardiovascular disease. They chose subjects with diabetes who also had increased triglycerides. They had a control group in this study, and the control group actually got mineral oil. And there were some concerns that maybe the mineral oil was inflammatory. And so maybe there was a problem with the baseline. And so the EPA looked better than the mineral oil. The study used a high enough dose to reduce triglyceride levels. Some people think that the EPA is an especially good precursor for anti-inflammatory lipids. One of the side effects of this was slightly increased GI bleeds. And so some people wondered whether the major effect was really a platelet effect and not a lipid effect. There's also studies that suggest that the kind of lipids that come from EPA do signaling events. Or maybe there's something special about EPA we don't know. So the real reason this worked, we don't know. Okay, I'm going to finish by telling you about a different problem that you see. This is a woman with too much fat in the blood. So the patient is a 38-year-old woman with type 2 diabetes. If you're a diabetologist or an endocrinologist, you see this patient commonly. She had a hemoglobin A1C of 12%, so she was poorly treated. She shows up with a triglyceride level over 5,000, and she had had a triglyceride level of those at 5,000 also during her pregnancy, and she developed pancreatitis. And now you see her, and she has pancreatitis again. So what is her problem? There are occasional genetic deficiencies of several rare genes, lipoprotein lipase, ApoC2, a gene called ApoA5, and several others that are associated with hypertriglyceridemia and pancreatitis during childhood. They're very rare. They occur in about 1 in a million people. And they often occur, early on in life. Often the story is of a child or a baby who has difficulty eating high-fat foods. More commonly, hypertriglyceridemia and hypertriglyceridemic pancreatitis occurs in this kind of setting. Some of these patients have heterozygous defects in some of the same kind of genes that cause the homozygous defect, but on top of it, they have something else. And the something else is usually obesity and type 2 diabetes. And that's what this patient has. This is pretty usual. So what do we do for this patient? What do we do when she's admitted to the hospital? So most of these patients, their triglyceride levels will drop. They drop about 50% with no food intake. And you see it overnight. And they usually get better. Obviously, this lady needs her diabetes treated. Sometimes, actually, when these patients come in, when you put them on no food, they actually have normal glucose levels. If not, they need a treatment for her diabetes. Even if her glucose levels are normal, many people will put her on low-dose insulin. So not the levels of insulin you use to treat diabetic ketoacidosis, but 1 unit of insulin an hour, just enough to block fatty acid release from the adipose tissue. And the thought is that free fatty acid from adipose will go back to the liver, get put together as triglyceride, and resecreted. So that's why low-dose insulin, at least physiologically, makes some sense. Patients do not need plasmapheresis. Maybe occasionally, maybe during a pregnancy when estrogen levels are very high, but normally this is not really needed. You should know there are no really good evidence-based clinical trials of any therapy for hypertriglyceridemic pancreatitis. Neither studies of plasmapheresis nor even studies of the insulin drip. She should get better. And then when you send her out, she needs better diabetes control. She needs weight loss. She needs low fat, low cholesterol, low carbohydrate diet, especially free carbohydrates. She needs no alcohol. She needs to be warned not to have estrogen compounds. And then she goes on fibric acids, which are the easiest to take, and probably some omega-3 fatty acids. Some of these patients I also put on GLP-1 receptor agonists because I'm hoping that I can get them to lose some weight on top of everything else, which is probably a major way to treat this disorder. So these are difficult patients to treat. So when somebody comes in my office and they have high cholesterol, I have a lot of drugs for them, and I could treat it pretty easily. This type of hypertriglyceridemia is often difficult. If the patient does not change their lifestyle, change what they're eating, increase their exercise, lose weight, take care of their diabetes, this can be a recurrent problem. So we have several new things. They will be around within the next couple of years. So the first is an inhibitor of a protein called angiopoietin-like protein 3, or ANGPTL3. The story of this actually starts several decades ago when the man who's boxed in the middle there, Gus Schoenfeld, followed a family in St. Louis who had hypo-beta-lipoproteinemia. So they had very low circulating levels of triglyceride, very low levels of LDL, and actually they had very low levels of HDL. So all the lipids in the blood were very low. The surprising thing is that most patients with very low LDL levels, something called hypo-beta-lipoproteinemia, actually get fatty liver. It's a risk factor for developing non-alcoholic fatty liver disease. But this family did not. So people didn't know what was different. And then about 10 years ago, this paper came out that was a summary of patients from all over the world, and they turned out to have a defect in ANGPTL3. So what does this do? So ANGPTL3 is a protein made in the liver. It circulates in the blood and inhibits lipoprotein lipase. So if you eliminate ANGPTL3, lipoprotein lipase will be more active, and that's why triglycerides go down. LDL cholesterol also goes down, I think probably because elevated or marked increases in lipolysis make a remnant particle, shown here cholesterol-rich TRL, and I think this remnant rapidly goes back to the liver rather than completing the conversion to LDL. Although this physiology isn't all worked out. There are antibodies to ANGPTL3, and there are antisense to ANGPTL3, and there's developing silencing RNA to ANGPTL3, all of which have been described within the last couple of years in papers in New England Journal. And they're in advanced clinical trials. The second therapy that's likely to be coming along is against this protein called apolipoprotein, or ApoC3. This story started about 12 years ago in a study of a group of people called Amish in Pennsylvania. And Dr. Schuldiner and his colleagues found that many of them had very low triglyceride levels and low risk of cardiovascular disease and a defect in production of ApoC3. Companies jumped all over that. And what they found was not only did ApoC3 reduce triglycerides in people with high triglyceride levels, but it even lowered triglycerides in people who are lipoprotein lipase deficient, as shown in this New England Journal paper. And that was curious because people thought ApoC3 also was a lipoprotein lipase inhibitor and therefore shouldn't have worked in this setting. But it did. And it did because the C3 has other actions, and loss of C3 increases lipoprotein uptake by the liver. Most relevant to this conference, about 6 months ago, this paper came out in the Journal of Clinical Investigation from a group at University of Washington. What they did is they studied patients in a clinical trial in a long-term study called CACTI, which is from University of Colorado. They measured blood ApoC3 level in those patients, and they found that people with type 1 diabetes who had more cardiovascular disease also had increased levels of ApoC3 in the blood, even if they didn't have hypertriglyceridemia. And they went on to show that the C3 was stimulated by insulin deficiency. So C3 is a risk factor for diabetic vascular disease, and may be another reason in the future why this is something that we target. So this is the take-home message. It's from this talk. Atherosclerosis is a two-way street. It can get better if you lower cholesterol. It goes down with any kind of agent. There's nothing probably magical about statins. Anything that lowers cholesterol and lowers LDL cholesterol should benefit vascular disease. LDL, the lower is better. And then expect new approaches to triglyceride and new drugs for LDL. Thank you.
Thank you so much, Dr. Goldberg. That was the best 30 minutes that I have listened to in a long time. Fantastic. And I'm sure people globally have gained a lot by listening to you. We would have time only for 2 questions. The first question is, as you said, that lower LDL is better and we could go down to 20 or 30. What should be an inflection point for triglyceride? When does it start affecting the cardiovascular system? Is there a level that we should look at?
Yeah, so people have thought that 150 is probably a level that alters other lipoproteins. It's the level that starts to cause an increase in the so-called small dense LDL. The Resolve It trial actually had people as low as 135. And if you look at normal, healthy people, their LDLs, their triglycerides are usually below 100. However, the truth is we don't know that the triglyceride reduction is what made a difference in that trial. Similarly, if you do a subgroup of fibric acid trials, like the one from Accord, fibrates look like they're beneficial in people who have high triglycerides, but it's totally unclear whether the benefit is due to some other action of fibric acids. You heard yesterday about the IRIS study that had a PPAR gamma drug. Fibric acids are PPAR alpha. It's not at all clear that they don't have direct vascular benefits, and whether the triglycerides are really what we should be approaching. So,
thank you so much. Would request Dr. Makkar to ask a final question.
Yeah, Dr. Goldberg, very interesting. You showed this patient example who had very high triglycerides and pancreatitis, and you mentioned that you would like to put these patients on GLP-1 analogs, which I suppose is a labeled contraindication if the patient has pancreatitis. So what is your take on this?
Yeah, so I'm sorry. So I somewhat misspoke. When I see hypertriglyceridemic patients like this, I will put them on a GLP-1 drug. But you're correct. If they had a history of pancreatitis, I avoid it. I avoid it because there is some concern about it. Some people will say that the data is not very strong on whether GLP-1 really affects pancreatitis. But you're right. In the setting of pancreatitis, I will avoid it because I don't want to be accused of putting somebody on something, especially because these patients are likely to recur. I'm glad you mentioned that. I misspoke.
Thank you so much.
One more quick question. Just one quick question. Do you have, there is a dual PPAR alpha gamma balanced agonist available in India called saraglitazar, and it's also in studies for NAFLD in US. Do you have any idea, or you want to make any comment on that?
No, but I in the past, combination drugs have not done super well. PPAR alpha, PPAR gamma drugs, and so I haven't seen the more recent data on those drugs.
But it's available in India and approved for treatment of hypertriglyceridemia and diabetes both in India. But Rajiv, you can conclude the session.
Thank you so much, Dr. Goldberg. That was a wonderful 30 minutes. We would end the session now. Over to Dr. Sanjay Agarwal. Thank you so much. Thank you, Dr. Makkar.
Thank you very much, Dr. Goldberg.